Dr. St. John?
Yes, hi.
Hi, this is John Fernandez with marketing. How you doing?
Good. How are you, John?
I'm great. Is this a good time to talk about?
Yes.
Oh, great. And I know Carmen was not going to join us. She was originally, but I'll fill her in.
Okay.
I'm the one who usually gathers all the information and writes it up anyway. But
Okay.
I
gotcha.
appreciate your time. And obviously, we wanted to. I guess I could also do a blog article about it, and where we mention our general position on this very, very widely publicized trial, the so-called ischemia trial, that's got a lot of headlines the last couple of weeks, and I've been reading it, and I know the headlines say stents no better than drugs for many heart patients, according to one major headline, and
Right.
But I know there's a lot of other details involved in this, including the fact that those who do have stents and invasive who do have procedures may have a quicker recovery, and so there's fairly two sides to this. But so what do we want to, I guess, relate to our to the health consumer out there, to our readers regarding our position on this aspect?
I think one of the things that we want to relate is that patients with coronary artery disease have two very good options. And I think one thing we sometimes do not well in medicine is say, well, you have to do this or you have to do this. And especially when it comes to invasive options, I think even in the cardiology community, sometimes, we see an abnormal stress test and the knee-jerk reflex as well. You have to have a stent. And I think this study and others continue to reinforce the notion that what we call GDMT, or guideline-driven medical therapy, so good medical therapy for stable patients with moderate to severe ischemia, and we can come back to what that means. Good medical therapy is as good as an invasive approach, and there is no difference in mortality. So in this trial, which was randomized, and it looked at patients that many of us would simply have capped and put a stent in, those with moderate to severe amounts of ischemia on a stress test.
Right.
They were randomized to guideline-driven medical therapy or guideline-driven medical therapy and a cath plus minus PCI or cabbage. And at 4 years, mortality was statistically the same in both groups. So I think the take-home message is you have options. We need to discuss with our patients so-called shared decision-making. The conservative approach, it may involve you taking more medicine for angina control. That is a possibility. And you may have slightly more risk of needing a cath in the future. The invasive approach has higher upfront risk, so the occurrence of the primary endpoint in the first 2 years was higher in the invasive approach. What that means in plain English is there is some complication rate around having a PCI or a cabbage, so peri-procedural MI or slightly higher risk of stent thrombosis. So if you don't have a stent, you can't have a stent thrombosis. But the invasive arm at 4 years out had fewer use of anginal medications. So what we've seen in other studies is PCI is good mostly for reducing angina. It can, in some patients, do that better than medication alone. But it doesn't prevent heart attacks, and it doesn't change mortality in the stable patient. And I think the other important thing to point out to people is who this study doesn't apply to. So it did not include patients who had recently or were having a heart attack. That is not the audience here. So those people are best treated with cath and PCI. It did not include very symptomatic patients. So people with chest pain at rest or with minimal activity were not randomized into this study. So they probably went for cath, and if there was obstructive disease, probably had stents put in. It didn't include people with left main stenosis. That's the main artery, as you may know, to the heart. So those people are felt best treated with PCI or surgery. And it didn't include people with a low ejection fraction, less than 35%. So people with a weaker than normal heart muscle. So I think it's important to remind people what this doesn't apply to and not apply to people to whom it doesn't apply. But for the patient with stable coronary artery disease who has angina a few times a week or with certain activities, who has a positive stress test, moderate to severe, and then is diagnosed with coronary disease either by coronary CTA or ultimately by cath, they have options, and no option is definitively better than the other. And I think that really is a take-home message. People don't have to feel sort of pushed into one position or another, and if their preference is an invasive approach, I think this is a reasonable study that says, yeah, you can do quite well with an invasive approach, and you are likely to be on fewer anti-angial medicines. Right. Or if you prefer to not undergo a procedure, then we're not increasing your risk of death. We're not doing you a disservice.
Right.
The notion of options, I think, is important.
Right, and I think you said it very well there. If anything, this may prompt more careful consideration of options for those with the so-called stable heart disease that you mentioned, not the others. Right. who are not candidates necessarily. So, if anything, it will be more. There will be more, maybe more discussion, more of options for these select patients, and I guess, right? I mean, that pretty much is.
Yeah.
Yeah. And
I think so, and I think sometimes the press goes one step too far. So I mean, I think, and I haven't looked closely at I think I read one of the New York articles time that was forwarded to me, but it's not so much that stents are bad, but not everyone with coronary disease needs a stent, and I think sometimes that's the impression that patients are given.
Okay, that's a great point, and I do agree with you. I mean, I being a former member of the media, they tend to slightly exaggerate, or maybe not quite clarify in the initial. Certainly, the headline is never quite accurate. But that's and this this study is federally funded. It's an international study. It was highly anticipated, and I guess there's nothing really shocking, or that's. I mean, I don't know. I mean,
I agree with you. I think this is really just a confirmation, if you will, of at least two earlier studies. So this is the largest randomized trial looking at stable coronary disease and medical management versus PCI, and it follows on the heels of what is probably now decades-old trials looking at similar things but with smaller groups. So the Courage trial and the Barry trial, or one subset of the Barry trial, looked at these types of patients. I think their entry criteria were after you'd had a cath, not just after you've had a positive stress test. But so this was a larger, I would say, better done, more broadly applicable version of earlier studies. And every time we look at this in cardiology, again and again, stents in stable coronary disease don't save lives, but they treat symptoms. Then there was the controversial Orbita trial, a much smaller trial that did a sham procedure on patients. So people went into a cath lab. They thought they were having a stent. Some went into the cath lab, did get a stent. And some of the benefit that many of us believe very strongly, well, stents treat symptoms, it became a little bit clouded. Well, do stents really treat symptoms, or is it the placebo effect of thinking that you had a stent and being told you will feel better? But that study notwithstanding, I think this study, on the heels of the prior study and basically all the data that we have to date, is that stents are good for symptom management in stable coronary disease. We don't yet have suggestions that stents prevent heart attacks. And I think that is still something to this day. It's hard for, I think, lay people and many physicians to accept. So I think this study, again, gives you the ammunition to say, look, you have options, and no one option is clearly better than the other for certain patients, and it really has to take into account shared decision making, what your preferences are, and sometimes preferences are going to be influenced by your age, by your your interest in not being on so many medicines and other things,
and lifestyle modifications, which are important. I mean, healthy eating and
Absolutely.
exercise, and if you can exercise and that kind of thing. So,
Absolutely.
and that, as you know, you very well know. Anything else? I think I got plenty here, and then what I'll do is I'll write something together by hopefully next week, and send it to you,
Sure.
and I think it's pretty clear. Yeah, I mean, we'll clarify it and say not for these certain candidates, these certain patients with stable heart disease, and we'll describe what that is, and there are options, and a lot depends on the shared decision making and all the other factors
Yeah.
involved, and yeah, I think we understood that stents don't necessarily prevent heart attacks, but yeah, it treats, as you said, treats symptoms and can be effective in diminishing, I believe, angina symptoms or
Exactly.
sooner.
So yeah, that seems to be a recurring theme that they also the patients who get stents, more of them are on fewer medicines down the road than patients with the less invasive approach. But yeah, so those are factors that you would discuss with patients as well.
Okay, good, Dr. St. John. Thank you so much. I think this is very helpful, and we'll be in
Well, I
touch.
appreciate it.
We'll be in touch probably hopefully
Perfect.
next week, and have a great Thanksgiving.
Perfect. You too. Thanks so much.
Take care.
All right.
Bye bye.
Bye bye.